Thank you for the opportunity to present on fetal and neonatal alloimmune thrombocytopenia. I'm Joanne Verweij. I'm a maternal fetal medicine specialist from the Leiden University Medical Center, and I'm presenting on behalf of our collaboration LUMC St. Quinn, the research team on alloimmune diseases. My conflicts of interest are as follows. I'm PI of the Frisia study by Johnson & Johnson and also of the natural history study of the Rallybio. I'm not personally receiving any payments. So the outline of today, I will start with the pathophysiology of FNAIT, but also compared to HGFN, the HIP study, screening, should we screen for FNAIT, and future perspectives. We start with an overview of HGFN. The fetus is semi-allogenic by nature, but generally well tolerated by the maternal immune system. In a miraculous way, this is interrupted in HGFN and also FNAIT. In all pregnancies, fetal cells come into the maternal circulation. The clinical manifestation of the conditions depend on the target for the maternal alloantibodies. So in HGFN, and the most classic, as we all know, targets fetal red blood cells. And this results in fetal anemia. As you see, the RHD negative mother has contact with the RHD positive child. The mother forms antibodies towards the RHD antigen. These pass through the placenta, and there they find all these cells, positive cells, that are destructed, and hemolysis occurs. It's a bit similar for FNAIT. There is a difference or incompatibility for human platelet antigens between the mother and the fetus. And again, this induces complications. We see that antibodies are formed and cross over the placenta back to the fetus, where these target cells are found. In FNAIT, it may lead to intracranial hemorrhage, and FNAIT is defined as fetal or neonatal thrombocytopenia because of this process. Although FNAIT and HGFN have similarities, there might also be a very important difference. We will come back to that later. As far as we know now, there are currently 41 different HPAs, human platelet antigens. Approximately 80% of the FNAIT cases in the Caucasian population are caused by alloantibodies directed to the HPA-1a epitope. In addition, anti-HPA-5b results in 15%. And you see that the occurrence of the differences of HPA differ throughout the world. So it's important to look at your own context. What we know now, HPA-1a is the most important human platelet antigen, and again, it causes alloimmunization. Sadly enough, the antibodies are transported over the placenta to the fetus, and platelet destruction occurs. What I was already saying is that FNAIT has a distinction with HGFN. We feel that there is still a black box. We don't know exactly, but we believe it has to do with the interference of endothelial cells. And And that's also the reason that we sometimes find normal platelet counts, but severe complications. If the platelets are destructed, there's an increased risk of bleeding in the fetus and neonate. And the most feared complication for that reason is the intracranial hemorrhage. Most of the patients are diagnosed too late in the first pregnancy. It's around 60% of the patients diagnosed with FNAIT. The aim of treatment, postnatally or sometimes also already antenatally, is to reduce complications, but we can't undo the complications and the consequences of the intracranial hemorrhage anymore, mostly. In subsequent pregnancies, after ICH appeared, we know there's an increased risk and we can treat. Most of the treatment, most people treat with IVIG, sometimes with corticosteroids, and also with intrauterine platelet transfusions, although that's not done broadly. When we're talking about screening, we know that there will be a totally new group of patients, because as I said, in subsequent pregnancies, we start antenatal treatment to prevent complications. We make a difference between patients with or without ICH in history. But if you screen, you don't know this history yet, and it will be not doable to treat all patients. So we have to make a difference, or we have to find a way to find the high-risk patients without knowing whether they have an ICH or not, because that's the whole point you want to prevent. So how do we diagnose FNAIT? When FNAIT is suspected, we do HPA typing of the mother, the father, and the fetus, and look for incompatibility. We also look whether there are antibodies present. And lately we found out that if you look at the HLA-DRB3 status, you also, if you find this positive, the chances of disease are higher. Together with this information, in the Netherlands, we did quite some research on the question whether we should screen. We followed the Wilson and Younger criteria, and we found that there might be an opening or a reason to start screening, and it might also be cost effective. So Jan Winkelhorst and Thijs de Vos, they worked both on these questions during their PhDs and performed a very large study, the HIP study. Blood was collected in all RHD and RHC patients, and we were looking for the following outcomes. So the incidence of clinical detectable severe FNAIT, obstetric and neonatal outcome, risk factors for severe hemorrhage, and HPA immunization. As I said, we collected all blood at 27 weeks. This is a standard moment to do antibody screening for RH. And we collected more than 150,000 tubes of patients, and they were typed on HbA1a. And this resulted in more than 3,000 women that had HbA1a negative pregnancies. And if we look further, 89 women were HbA immunized and incompatible. If we look at the complications of bleedings, we saw that this is a very rare occurrence, luckily. We saw 1 case of a major bleeding and 3 cases of a minor bleeding. There are many more results, but we found, as in previous history, previous literature, there were conflicting reports before about the extent of what antibody levels were saying and predictive for severe disease. But in our cohort, we saw that the patient with the most severe bleeding also had the highest level of HbA1a antibodies. And there was also a clear association between HbA1a immunization and the HLA-DRB3. And this was also in line with earlier previous studies. Interestingly, the number of pregnancies or previous births was not a risk factor of developing HbA1a antibodies. How this comes about is a subject for discussion and future research, because that's, I think, what we still believe is that there's many unknown about FNAIT. Also, there were some interesting clinical outcomes. HbA1a immunization is related to hypertensive disorders, so be alert for these patients to develop high blood pressure or preeclampsia. And neonates of HbA1a immunized women often born prematurely and smaller for gestational age. Again, look at the growth of the baby and be alert for premature birth. As noted, previous pregnancy or delivery was not at risk, and it's interesting because that also underlines a different mechanism of HDFN. The incidence we in total found of HbA1a negative pregnancies was 11 in 10,000. Lastly, on clinical outcomes, there are studies that found a correlation with miscarriages and intrauterine fetal demises. And I think it's important to do more research on that as well. So I think we can conclude FNAIT is a severe disease you want to prevent, but we can't prevent everything. You have to look more on a public health view. But do we believe it's time to screen? We learned in the last years a lot about FNAIT, but also about risk factors and how to define this higher risk. So if we come back to the screening principles and the principles of Wilson Young, we believe it might be time. And we are happy that our Dutch Health Council is looking into this now. But we have to learn a lot when we are doing the screening. And that's why Thijs de Vos called his PhD, "The proof of the pudding is in the eating," because we are unaware of many aspects before we really start screening. This is a real new patient population, and we have to learn with each other in collaboration what the best policy is for patients that are screened on FNAIT. Just some challenges if you screen. So how do we do the follow-up? will we follow the HPA-1a antibody levels? How often do we do neurosonography? When do we treat? We can't treat everybody. Will we give IVIG with or without corticosteroids? When do we deliver? Because we don't know exactly what the risk is. Do we do accept vaginal delivery, or do we do planned cesarean? All these questions are open. And what we have learned is that there is already a big difference between treatments and management. Just to illustrate that it will be difficult to find a very hard consensus in this rare disease on what's the best management strategy. Even now, not even talking about screening. So if you look at the Norwegian management, they don't give patients who had a previous low platelet count of the neonate caused by FNAIT IVIG. They only give patients who had an ICH in the previous pregnancy IVIG. On the other hand, they do a planned cesarean for every woman that had an antibody level above 3. If we look at the Dutch management, we are a bit more defensive. We give patients with a low platelets IVIG. We give patients with high risk IVIG. But on the other hand, if they are getting IVIG, we believe, and we also saw in previous studies, that the vaginal delivery is safe. On the other hand, we also have been thinking for our patients that we might overtreat if we look into the data of the Norwegian colleagues. So lately we changed our management, and we now are still a bit more defensive than the Norwegian colleagues, but we give IVIG antibody levels, IVIG if the antibody levels are above 3. So if the antibody levels are not high, we don't give IVIG. And this also is similar for the screening group who is coming up with an undefined risk. We still give the patients with ICH in the previous pregnancy IVIG and tend to even start that a bit earlier. Again, if there is a vaginal delivery in history, we will accept a vaginal delivery if possible. We tend to get more consensus in the treatment of FNAIT, and for that reason we organized a Leiden consensus meeting on FNAIT last April. This was a very informative meeting, and what I think the most important aspect is, what we learned is that it's not only about evidence, but also about what you value as a risk, what the possibilities are to have IVIG paid. So many more than only the evidence that makes countries' policy, but also makes that it might be very difficult to come to real consensus. We hope to publish these results soon, but some preliminary data. So we couldn't find any consensus on the mode of delivery. We couldn't find consensus on whether high-risk immunized pregnancy should be treated with IVIG alone or also with corticosteroids. But we also have some points where we found almost consensus, and we were in line with each other that we think that if we proceed to screening for FNAIT, it should focus on the prevention of severe bleeding and not on the prevention of severe thrombocytopenia. Again, we found some consensus in alloimmune pregnancies, identified upon antenatal screening, the repeated measurements of antibody levels should be used to identify the pregnancies with an increased fetal bleeding risk. And that also includes HLA-DRB3. High-risk HbA1a immunized pregnancies should be treated in the next pregnancy. And a potential screening program should not include anti-HbA5b. So we hope to publish this manuscript soon and learn from each other and find out where we can reach consensus and otherwise what the reasons are not to find consensus. This is important to move on and see what we can do in research and looking at the best possibilities for patients with FNAIT. Rallybio is developing a prophylaxis. It's a monoclonal anti-human platelet antigen. And like the anti-D for HCFN, this might be a future perspective that will prevent FNAIT. As noted, it's a rare disease, and for that reason, we have international collaboration. It's absolutely needed to learn more about this disease. So we are having a working group, international working group, and it's called the Platonic Study, where we look at we focus on the HbA1b women that are identified by screening in different studies all over the world, and we tend to collect data, samples, and placentas in a uniform way, but we use our own management strategy to enable to look at the differences and also to find out what works best. If you want to learn anything more about this study or want to collaborate, we are always open for that, and please email to fnaidstudie@lumc.nl because you're very welcome to join us. So in conclusion, we started with an overview of HCFN, and I just want to highlight the differences between HCFN and FNAIT. So HCFN is targeted by the red blood cells, FNAIT, the platelets. In HCFN, most of the immunization occurs during delivery, while we know that FNAIT occurs mostly in the first pregnancy, already in the pregnancy. The most frequent antibody for HCFN is anti-D, as we all know. In FNAIT, it's anti-HbA1a. The severe outcomes differ. So we know that HCFN and FNAIT have severe consequences, both resulting in fetal or neonatal death. But in HCFN, we find hydrops fetalis and kernicterus, while in FNAIT, we find intracranial hemorrhage. In HCFN, we know that we can treat with intrauterine transfusion and exchange transfusions. And in FNAIT, we know you can do IVIG. For HCFN, there's a very effective screening possible with prophylaxis, but also monitoring during pregnancy to prevent complications by ultrasound. In FNAIT, we don't have screening. We have prophylaxis work in progress, but that's far from being clinical care. And there's no opportunity to do monitoring during pregnancy by ultrasound. Although we know and learn much every time more about the antibody levels that can be helpful to determine and to treat before it's too late. The future perspectives are stated as follows. We have considerable knowledge gaps on the pathophysiology of FNAIT. So we really need to work together to learn more. We're questioning whether we should do screening, and we hopefully have prophylaxis in the coming years. And as stated before, collaboration is needed in rare diseases. I'm not doing this on my own. There's a very big ambitious group from Sanquin working on FNAIT and HGFN together with the team of Leiden University Medical Center, and with many of you collaborating. So thank you so much, and please email me for any questions through fnaitstudie@lumc.nl, or my email is in the top, e.j.t.verweij@lumc.nl. Thank you very much again for this opportunity.